talk about the symptoms, because I don't know how many people were at my last one. I talked about vestibular exercises and all sorts, but this time, in conjunction with Kevin, I've labelled it vestibulopathy, and I've also put symptoms down. So I'll look at some of the terminologies that we use within the medical system, discuss some of the symptoms, and hopefully get you to understand why you get those symptoms. And then Kevin mentioned something about the Covid-19 or the coronavirus situation. So I've just added something at the end about the coronavirus and my take on that. So this is a busy slide with lots of sort of acronyms. So these are the sort of terminology. These are the things we put in notes. These might be in any letters you get from the hospital. And sometimes they can be quite confusing. So I thought I'd go through some of these, what they mean. It's only a relatively short presentation today, so it's hard to go to every single one in detail, but probably everyone that's on today will have a combination of these things on the screen. So first of all, starting with vestibulopathy, it's a label. I mean, we're using it as a diagnosis, but it's a label. So, and it comes from putting those two words together. Vestibule is the inner ear balance organ. So the vestibular system is the balance system. So, and then opathy means it's not working properly. So either it's damaged or it's not normal. So vestibulopathy just means if you've got that in a referral letter from, one of the doctors in balance, it means that something has damaged your vestibular system and it isn't working properly. So it gives you a vestibulopathy. It's not good or bad. It's just a name. So it's called other things. It's called vestibular hypofunction. So again, vestibular, the inner ear. Hypofunction means it's underactive. Or vestibular dysfunction, again, vestibular system, but not working properly. It's dysfunctional. It's not working. And in medical terms, really, vestibulopathy comes about because a person has a vestibular problem and they haven't compensated to it. So it could be an uncompensated vestibular problem. So if you have those in any letters you've got from the hospital, they're all the same thing. It just means your inner ear isn't working properly. And it can be on one side, unilateral, or it can be both sides, bilateral. So let me move into some of the diagnoses you get on letters. And if we look at these individually, it's a very common one, BPPV, benign paroxysmal positional vertigo. Very common, it's a very common balance problem. I will be discussing a little bit of detail about it, how it occurs, so you can understand it. But I think Professor Ray has probably covered that if you've seen him present. And then he's probably covered this one as well. This is the new label in the categories. It's PPPD, so it's triple PD, persistent postural perceptual dizziness. But once again, it's a label. I mean, having that doesn't tell you what's wrong. It's telling you what you're feeling. Whereas BPPV, the first one, sort of tells us what's wrong. But the second one is just a label when you've had symptoms for a long time and you become sensitized, which I'll show you in a minute. Then some of you may be unlucky enough to have something called SCDS, and it's that superior semicircular canal dehiscence syndrome. I'm not going to be covering that today, purely because it's a very, very rare condition, but obviously in our centre we do see people with it. And basically it means you're born with a little bit of weakness in the bone in your superior semicircular canal. So the roof of your vestibular system has got a weakness in it, and then pressure can go through it. So sound or coughing or sneezing can interfere with the fluid in the balance organ. It's a very rare condition, but you may see the acronym used. MD. This is usually for Meniere's disease, but its proper name, when Meniere's disease is named after Prosper Meniere from, I think, in the 18th century. But it's endolymphatic hydrops is the condition. So the endolymph is the fluid in the inner ear, in the vestibular system, actually, and the cochlea as well. It's all the same fluid. So the endolymph, that's the fluid that's in your inner ear. Hydrops means the pressure changes. So Meniere's disease is called endolymphatic hydrops. So when you have a Meniere's attack, something causes the fluid pressure to change in your inner ear, and we don't know what causes that. Then there's migraine-associated vertigo. And it's sometimes, I put in brackets there, it also sometimes is called vestibular migraine. This is a relatively new diagnosis, but it covers lots of conditions because that they overlap. So migraine-associated vertigo, it's a migraine, but it doesn't mean it's not classic migraine. It's not necessarily a severe headache that makes you feel really sick. You have to go into a dark room. Instead, you can have quite severe vertigo caused by the migraine. And again, Professor A's probably discussed it in any presentations he's done, but this is a proper diagnosis. And then vestibular neuronitis, VN. So this means the vestibular nerve has been inflamed for some reason. It's been irritated. Usually a virus does it, so it's vestibular neuronitis. Many years ago, the GPs used to call it labyrinthitis, and that still does exist, the term labyrinthitis, but the labyrinth is the entire thing. So I don't know if I show you, you can see that I'm just holding up now. That's a plastic model of the entire labyrinth. So if something upsets the whole thing, you have labyrinthitis, but more commonly it's vestibular neuronitis, only the vestibular component is affected. And then lastly, I put at the bottom there, in the past, migraine-associated vertigo used to also be called migraine-associated dizziness. But when you put a diagnosis of MAD down in someone's notes, it didn't always necessarily look good. So if we used the word MAD, it was migraine-associated dizziness. We didn't mean the person was mad. But now we've moved it over to migraine-associated vertigo. So they're the diagnoses in that pile of terminologies I showed you. The treatments, these are the terminologies. So looking at these, VR, vestibular rehabilitation, this is what we do in the Balance Clinic to treat vestibular symptoms. It's also often called vestibular retraining therapy, so VRT. So VR and VRT, same thing. And then VR with VR, that often means vestibular rehabilitation with virtual reality. So we're starting to use virtual reality, whether it's on phones or iPads or computer screens or in the proper mask setups with treatment. So you might be referred for VR with VR. And this is an important one. The correct terminology, and this is how it should be written down, is CRM, which is a canalith repositioning maneuver. You may have seen it as the Epley or Sermont. So they're the name of the people that put their names to the CRM. So there are lots of different canalith repositioning maneuvers. These are the two most common ones, but there are other people and they put their name to it. So that's why you say, I've had an Epley maneuver or I've had a Sermont maneuver, but really you've had a CRM, a canalith repositioning maneuver. And you may have had Brandt-Duroff exercises, so BD exercises. So once again, these are named after two people, Thomas Brandt and I think he's a Russian guy called Duroff. So I've met John Epley and I've met Thomas Brandt. So I've met half of the names on that screen. So looking at those, so they break into two categories, and that's because the treatments, vestibular rehab, vestibular retraining therapy, or using virtual reality, they're exercise programs. So we give you exercises under this remit. And they're treating vestibulopathy. That's what they're treating. Whereas, so this is my Mr. Dizzy coming to the clinic, and he's got unilateral vestibular hypofunction and require vestibular rehabilitation to aid my compensatory process. Some of you may have seen that slide before. Whereas the other treatments, the canalith repositioning maneuvers, Epley and Sermont maneuvers, and Brandt-Duroff exercises, they treat BPPV. This is the benign paroxysmal positional vertigo. So we'll go back a slide there for a minute. So, so these are when you come to the hospital and the doctor says, you know, I've had an Epley, or no, you say to us, we've had an Epley maneuver, the GP's done it. So that's for treatment of the BPPV, which I will discuss shortly. So quite often, though, these are the things the GPs now are getting, I won't say better at doing, but that's what they're doing. But we do see a lot of people who have actually got vestibulopathy, not BPPV. And so if they're doing Brandt-Derofft exercises or having Epley maneuvers and they haven't got BPPV, it won't make any improvement for them. So we have to treat the right thing. Now, terminology. Some of you may have been labelled or told you've got visual preference. And of all the things, this is, in a way, one of the hardest things to understand, except when patients have got it and I can get them to understand, it explains lots of their symptoms. So visual preference is labelled other things. It's often called supermarket vertigo, or it's called visual dominance, or we might say you're over-reliance or reliance on your vision, and Professor A often says you're using your eyes to balance. So all of those are the same thing. It's visual preference. And as the definition says there, visual means eyes and preference. So you've got a preference for using vision. Now you think, well, what's wrong with that? Well, we use our balance system. The brain uses the correct balance sense to believe at any time. And in the normal situation, when you haven't got any problems, the brain is automatically picking the correct sense. It might be your eyes, but it's usually your ankles and legs. It might be your ears. So if you have visual preference, we use that as a label when people are using it when they shouldn't be using it. And they're not deliberately using it. You're not going out of your way to develop visual preference, because it's what creates the symptoms people often hate the most, which is the nausea. It gives you symptoms in visually challenging situations, such as going into a busy supermarket, which you'll see later, going into certain crowded places, or if you've got certain patterns around you, certain coloured wallpapers and things, it makes you feel ill. And you get visual preference because it's how your brain copes with a vestibular problem. So the visual preference isn't a pathology. It's not a medical problem. The visual preference is what your brain is using to sort out because you've got a vestibulopathy. So your brain isn't trusting your ears because they've been damaged. So it starts overusing your vision. And sitting perfectly still in a nice room, it doesn't matter if you're using visual preference. But if what you're looking at starts moving, say a screensaver or a TV program starts scanning around, then it actually makes you feel like you're moving when you're not. So visual preference is a situation where your eyes can trick you. So I won't keep this on long. It shouldn't be too small on little screens, but this is an optical illusion. If people feel queasy with it, just close your eyes for a few seconds. But it's a deliberate optical illusion to give you a sense of motion. And for those that can see it quite well, if you want to stop something moving, you look at the bit, so there's my mouse moving here. If you look at the fixed points, this bit stops moving, but then it starts moving over here. And you look over here at this point, then it starts moving over here. So that's an optical illusion to create a sense of motion. But I'll come off that now, because a person with visual preference, I've actually had people vomit in my office when I've shown them stuff like that. So I've learned not to do it. I can do it in a talk now because I can't see you on the screen. So if anyone's been sick, I'm sorry. But I did warn you to close your eyes. So visual preference creates symptoms in situations when you shouldn't be using your eyes to balance. And the classic one is in a supermarket. When you walk into, say, Tesco's or Sainsbury's, your brain automatically sort of looks to your inner ear, your vestibular system, for balance, which allows you to walk down a supermarket aisle and look left and right at the items and feel normal. If your ears aren't working properly and you've developed visual preference, when you walk into that supermarket, suddenly your brain is using your eyes to balance when it shouldn't be, and it sees colours and patterns and movement, and you don't feel great. And the more you stay in there, you have to get out. And that's what people say to me. The terminology is that they go into Tesco's and they have to get out. They don't know why they have to get out. They just have to get out. And it's because the visual preference has overwhelmed them visually. So briefly, we'll look at anatomy, which I'm moving on to now. So this anatomy bit there, for those that can see me holding up, this is anatomy showing you that the vestibular system is made up of little loops, which are called semicircular canals. And then you've got a macula and a saccule, so in here. So they're all basically movement sensors, but basically they do actually, rather than picking movement up, they pick up acceleration and deceleration when you start moving and you stop moving, or you change the speed. And then the fluid moves and it deflects little hair cells, and that's what your brain interprets. So that's what's happening here. So balance is a combination of our, as I said, our eyes, our body, and our ear goes into our brain, and it creates awareness of movement. It controls our eye muscles, controls our posture, and it controls what we're doing, motor skills, how we're moving. So part of that, which we'll talk about now, which if you've heard me talk before, you'll know that your vestibular system controls your eye muscles. You might not know that. That might be a surprise. But your inner ear, your vestibular system controls your eye muscles. So when you move, your ears make your eyes move. And that's called the vestibular ocular reflex, often written in the notes as a VOR. And basically, signals from your inner ear, this thing, continually are controlling your eye muscles to coordinate your eye movement with head movement. So we need that working normally, so you have clear vision and normal balance when you're moving. And obviously, when you have a vestibular problem, that's what you lose. So when you move, your eyes move wrong, and that creates either blurred vision or a sense of imbalance, or makes you go off balance. So a simple VOR, in simple terms, moving the head to the right causes your eyes to move to the left, equal and opposite. So here we are, your head turns, and this looks complex, but it's not. It's a simple reflex loop. That's your inner ear. It's one nerve from there to something called your vestibular nucleus in your brain. There's one nerve goes from there to your ocular nucleus, or the eye muscles, and there's one nerve. So the VOR is a simple reflex, and it's only 3 nerves, and it hooks up your inner ear to your eye muscle. So when your head moves, the fluid moves in here, sets a reflex off, so your eye muscles move, and it actually goes to both eye muscles. So it's a simple reflex loop. In simple terms, turning your head to the left, your eyes move to the right. That's automatic. It's a reflex. You can override it if you want to keep your eyes on the bus that's coming towards you as you cross the road. Your brain can override the VOR, but if you don't worry about it, when you turn your head, your eyes just go to the right place. So that's important, because most of the symptoms our patients get relate to this imbalance between the 2 vestibular organs, which gives us an asymmetrical VOR, or an abnormal VOR. So when your head moves, your 2 ears tell your brain different messages, and your eyes move wrong. And if your eyes move wrong, that's what creates the symptoms. And for those of you that have been to the Balance, either London Road Clinic or the Leicester Balance Clinic, when you often have the testing done, we do lots of things looking at your eyes. And it's not because we think you've got an eye problem, it's because your ears make your eyes move. So that's where the problems show up. And lots of those things we do in complete darkness. You have your eyes in goggles, so you can't see anything, because if you've got your eyes open, your brain can stop them moving wrong unless you move quickly. So I've tried to put this into, I'd say, the simplified physiology of what I've just said. So if you can understand the next few slides, it goes a long way to understanding your symptoms. So these are the categories I'm going to show you. So here is it. So I'll go to there's the condition. So this is what your head's doing. This is what the left balance nerve says. This is what the right balance nerve says. And this is what the brain feels. So sitting perfectly still here now, if you're sitting really still, this is a condition. Your head's stationary. Your left nerve is firing. It's moving. So even when you're not moving, your vestibular system is firing in medical terms. The nerve's firing. We can say it's firing about 100 times a second. I'm taking a guess out. It might be 200 anyway. So what the brain sees is your left ear is, I'll use the word 200. So you can see it gets 2 crosses there. That means the left nerve is firing 200 times when you're perfectly still. Your right nerve is firing 200 times when you're perfectly still. So your brain sees this pattern, 200 pulses there, 200 pulses there. So your brain says, my head's not moving. Now that matches up with what your neck tells your brain, and it matches up with what you see. So when it all matches up, you feel fine because your eyes, neck and ears say you're not moving. So now I turn my head to the left. So I turn my head to the left, and what happens is the left nerve fires a lot more. That might go up to 300 pulses per second. So the brain sees 300 on the left. Interestingly, the right nerve, it gets inhibited. So it goes down to 100 pulses per second. So the brain now knows when you turn your head at 90 degrees in half a second, the left nerve fires at 300, the right nerve fires at 100. So that the brain is feeling that. So it says, I've turned my head to the left. Hope you're all with it. I've only got 4 people I can see, and they're all nodding. Actually, one of them is me, so 3 people. Anyway, I'm nodding as well, because that makes sense to me. But, so now, let's put up a slide showing when you've got vestibulopathy. So you had, 5 years ago, you had a virus damage your ear. 5 years ago, you got vestibulopathy. Well, the left side isn't working now properly. The left side isn't working properly. It's been damaged. The virus has damaged it. The right side's still working normally. So look, the right side, the brain is getting the information which normally matches that you're not moving. But the left side is underactive. Vestibular hypofunction, vestibular dysfunction. It's not working properly. So sitting, doing nothing, the brain sees that you're turning to the right. So that's why a lot of people feel a sensation that they're moving, because they're not moving, but this ear is underactive. This ear is normal. So the brain sees the pattern that they're moving. Hope that makes sense. Hope my 3 guests I can see understand that, because the aim of rehab is to make the brain see this as that. That's what the exercises do. So we don't fix the damage. We get the brain to, as a computer, to retune so it sees that pattern as this. But so any of our people who are watching who've got Meniere's disease, it's different. When you have a Meniere's attack, for whatever reason, say they've got left Meniere's, in a Meniere's attack, the left side goes hyperactive. It's very active, the left side. When you have a Meniere's attack, it might be firing at 400 or 500 times a second. The right side is still firing normally, that's 200, but now in a Meniere's attack, you feel like you're spinning because this side is massively higher than this side. So it's the physiology. So when you understand the physiology, you know what's going on. It doesn't make this feel better because it feels like I'd be on my chair spinning around. And that's why people in Meniere's attacks are often sick, because this is happening for an hour or 2 hours and they're spinning violently for 2 hours. And most people will be sick with that. So you can see, so that's the difference. Whereas the previous slide with vestibulopathy, it's underactive. With Meniere's disease, it can be overactive on the bad side. And so you get that sensation. So I put that slide back. So the symptoms to relate to the imbalance between the 2 vestibular organs, because you get an abnormal or asymmetrical VOR, which is what all those things were showing. That will show up in your eyes. So when you're having a Meniere's attack, your eyes are moving. So vestibular problems, whatever they are, have physical effects, they have sensory effects, and they have psychological effects, all of them. You don't just have one. So the physical effect will be that the nerve impulses are changing, your eyes might be moving. The sensory effects are what you feel, and you can't have horrible symptoms like vestibular problems give without psychological effects. Just not possible. So all patients have some element. If I say of psychological problems, it doesn't mean that they're psychologically or mentally unbalanced. It means that if you you soon learn not to go into Tesco's because you feel bad. So that's a psychological problem. You've got avoidance behavior. Sorry if you can hear my dog barking. It means my wife's probably come home. Someone's actually got a pair of scissors down there. Who's that? I can't see on the screen. They've gone. Who's that on the screen? Ian has left a pair of scissors on display. I don't know why. Can you all see that, or is it just me? No one can answer anyway. It doesn't matter. So we go on. So we look at textbook symptoms versus what people actually say. And then you'll know this, the symptoms range in this spectrum. You can have symptoms where you can go off balance and fall over, through to severe spinning vertigo. You can have sensations of rotation, giddiness or spinning, but you can also have sensations of rocking or swaying, because I've shown you the vestibular system turning left, seeing how your eyes move right, because that fits in nicely with rotation. But there are 3 spirit levels in each ear and something called the macular and saccule, and they pick up gravity that way and translation forward and backwards. So it's a multi-dimensional plane of movement. So you don't just have giddiness or spinning, you can have rocking and swaying. And you have strange descriptors: floating, drunk, lightheaded, cotton wool, off balance, falling, veering. So when you're walking, you're veering off. I meant to put brain fog on there because lots of people say brain fog. And people often, our vestibular patients often have a combination of neck pain, eye pain, strain, or headaches. They often have nausea. They often have their eyes lagging in their head. Now that is quite interesting, because that is actually a very good description of when you move your head. If your VOR is wrong speed, your eyes lag, and that's what you feel. So people tell us that. They have sometimes have strange sensations like water running down inside the skull, stinging nettles in the head. They often have things like pressure in the head, and it could be in the head, it could be behind the eyes, it can be in the ear. They often have memory lapses or lost confidence. A lot of our patients have problems in shops, and you can see there that one. Look at the patterns, and here shiny surfaces in crowded environments, and then in difficult places. I like these stairs, and people have seen me talk before. This is a magic labyrinth in London. One of our Menier's meetings was there, so all the Menier's patients had to come up these stairs to get to my presentation. I thought it was funny. They didn't. There was a lift. So, and it can lead to panic attacks or the sensation of it. So people develop a fear of going out, a fear of open spaces, or they might have a fear of enclosed spaces, because people's symptoms, they can have the same diagnosis and problem, and one person can come in and they don't like walking in wide open places, and another person comes in with the same diagnosis and they don't like walking in enclosed places. So it doesn't mean they're different. We just have to, I have to vary their exercises based on what they describe as symptoms. But I use the word fear. These are all fears, and that's when I say psychology comes in, because the symptoms create the fear. And so some of our patients do have panic attacks, but most of them don't have panic attacks. But panic attacks are one of the worst things you can have, because you're completely out of control with a panic attack. So I don't want to create symptoms that take people to a panic attack. I want them to understand why the open spaces. If a patient comes through and they can't do open spaces, you would have probably guessed I'll want them to do that in part of their exercises, but I want them to understand why the open spaces is difficult. And the same thing, if a person has trouble walking down little jitties when there's fences either side and it makes them feel really strange, I will want them to do that as an exercise, but I want them to know why they're doing that rather than just walking down it and feeling really strange. And then often people have looked on YouTube and Dr. Google, and they think they've got a brain tumor, they think they've got early Alzheimer's disease, multiple sclerosis, or that's Creutzfeldt-Jakob disease, mad cow disease. Because, you know, all of these things, if you put some of your symptoms into a search engine, it comes up with these sort of diagnoses, which is always slightly worrying. So, and that then adds to the worry that people feel. And then they do go into the system to see doctors, and then all the tests come back normal. They've had blood tests and they're normal. They've had x-rays normal. Might have had an MRI, it's normal. The blood pressure is fine. The cardiology is fine. So sometimes the doctors trying to be helpful say nothing is wrong. Live with it. get on with your life, which I think these things, I put them in quotation marks, as I think they're the worst things you can tell a person with a vestibular problem, even though the doctors might be trying to be helpful, because what they're saying is there's nothing serious wrong. There's not a pathology. So that's good. They haven't got a brain tumour. They haven't got Creutzfeldt-Jakob disease. They haven't got multiple sclerosis. You know, they're more worrying. They're serious things. But a vestibular problems create symptoms. So live with it means, well, okay, you've got to do something about it, and then get on with your life means be active. You know, I hope that's what they mean. You know, the idea is we want to retune the vestibular system. So I've created this, what I call the dizziness vicious cycle, number 1. So if you have vertigo or dizziness with head movement, you avoid moving your head. Your neck gets stiff. Neck's now quite immobile, so you don't compensate, which is how you get better from vestibular problems. So you still got those symptoms. So now you've got poor neck posture. Your neck is still getting stiff, and now you've got neck pain and headaches as well. And you still fail to compensate. And now, in addition to your vestibular problem, you've got chronic neck pain and chronic headaches. Sounds fun, doesn't it? But most of you have been there. And it goes round like that. So what we have to do is to get you to compensate. I'm trying to watch the time on my little timer there. But there's another vicious cycle that goes on. Look at this. So we got dizziness now. People worry, something's wrong with me. That's called somatic anxiety. Something's wrong with me. I'm dizzy. I shouldn't be dizzy. Look, causes a pre-conscious anxiety. You're aware of it now. You keep your neck still. You don't compensate. The dizziness doesn't change. So now you feel like you're scared of falling in the street. There's danger. That anxiety gets worse. You start avoiding things. You avoid going out. You avoid moving. And in addition to your chronic pain and headaches, you become a social embarrassment. So, and then that just goes round as well. So, so this keeps you in. You don't want to go out because you feel wrong. People think you look drunk, which is one of the big things. People don't like thinking that people say they're drunk, and then you can be scared of falling. So there's 2 vicious cycles, but there's a 3rd vicious cycle. I'm only going to briefly shoot through this one because I nabbed it off a website. It's the PPPD vicious cycle. And I'm not going to speak too much on PPPD because I think Peter Ray spoke on it, but PPPD comes about because you've had a vestibular problem. So there's a trigger, whether it's, look, labyrinthitis. This is from their website. It should be vestibular neuronitis. It could be migraine. It could be a head injury. So there's some damage done that causes dizziness. And this develops because your brain becomes hypersensitive to motion. But you get these same things. You get those 2 other vicious cycles. You get the anxiety one, avoid going out. But you also get fatigue, dissociation like virtual reality. You still get the neck pain and headaches and avoiding neck movement. So I've put this in because that is my last 2 cycles I've shown you. And that's how people can develop PPPD. And what happens here, in simple terms, their brain becomes hypersensitive to motion. And then, so they see people like me saying, we've got to move. And in fact, movement is quite provocative. So, so the treatment for that, which I'm not going to go into a lot, is still exercise to move, but it is also adding in a very mild antidepressant, not to be used as an antidepressant, but to take the edge off this hypersensitivity. So some low-dose antidepressants can do that. So it's not because we're saying the person's depressed, it's because that's the drug that's useful. So if we look at those 2 big diagnoses that we see in our balance clinic, and I'm not talking on vestibular migraine here because that's a big diagnosis as well, but as a physio, I can't influence that too much. But having said that, I do, because I talk about diets and things. But BPPV versus vestibulopathy, round 1. Well, BPPV is a mechanical problem, and we'll show you what that means in a minute. Whereas vestibulopathy is an electrical tuning problem, because you've seen there's some signals wrong. So you can have one, or you can have the other. So you might have a diagnosis of BPPV, you might have a diagnosis of vestibulopathy. You can have one, and then you can have the other. So you can have BPPV first and develop vestibulopathy, or you can have vestibulopathy and develop BPPV. You can have both at the same time. So even just this week, my clinic is at the Royal, I would have had people in all those 3 categories. They both indicate the vestibular system has been damaged, and they both respond well to the correct treatment. But if you've got BPPV and you're having rehab exercises, that doesn't work. If you've got vestibulopathy and you're having epley maneuvers, that doesn't work. You've got to have the right treatment at the right time. And because they change, sometimes you're needing epley maneuvers, and then when that's better, you might need vestibular exercises to retune it. So, as I said, both respond well to the correct treatment. BPPV responds to canalith repositioning maneuvers, of which the most common ones are epley or Sermont, but there are other ones like Gandolfi's or Gandolfi or Ganofi or something. And there's Brandt-Deroft exercises. So they're we do the maneuver to you, or you do exercises at home, whereas vestibulopathy, it's a range of vestibular exercises. But because a lot of people don't understand BPPV, I thought I'd give a quick run through. This is a very schematic. I got one of our artists at work to draw the vestibular system. So there's semicircular canals, there's a utricle and a sacral. Because in the anatomy, we've all got these otoconia, and they're crystals of calcium carbonate. They're like gravel. They're heavy little stones, and they're sitting in here and they're sitting in here. So we've all got them, and this is why the doctors say, oh, your crystals are out, or you've got a problem with your crystals. And then they look in your eyes and say, oh, yes, you've got crystals. Well, the crystals are not in your eyes. The crystals are in your ears. So these are the crystals. We've all got them. They're stuck in a jelly membrane in the macule and the saccule and the macule, and they're heavy little stones sitting in jelly over the hair nerve cells. So their purpose is, they're meant to be heavy, so when you accelerate and decelerate, they're heavy, so they move, or they lag behind and then catch up. If you bend your head forward, they all fall forward in the jelly. You bend your head back, they all fall back in the jelly. So they tell the brain where gravity is. So here we are, a normal person. Now, if we just, I'll do my screen like this, but then it doesn't change what you see. So that's the utricle and the macule here. This is the posterior semicircular canal. Some of their little stones from this picture, they've had a virus and it's damaged this. And a few of these little crystals or stones have fallen out, and they've fallen into the posterior semicircular canal. So now this tube, which is meant to have fluid in it, which it has got fluid in it, endolymph, they're sitting there, and there the little stones are. And then we do a test, and we put the head back over the edge of the bed. Well, look what gravity does. These little stones, gravity makes them move in the posterior canal. They roll down there, so they're rolling down here, and that makes the fluid move. When the fluid moves, your eyes move, and we look at your eyes and say, oh, look, you've got the crystals, because your eyes just don't move nicely. They violently spin because they're moving fast. It's like sand in a spirit level, and you tip the spirit level up. Gravity makes it move. That makes the fluid in your ear move, and then we can see that in your eyes. So we have you sitting first. We turn your head to put this spirit level in the best position for us, which means the worst position for you. And then we lie you back and we look at your eyes. And if you've got BPPV, your eyes roll. They flick and roll, and it feels horrible until these little stones get to the bottom. Then your eyes stop moving. Now, most people at home don't stay there long enough to know that it's going to stop because it feels so horrible. But when it stops, we then can tip them with the epley maneuver through the whole thing. So these little stones, the otoconia, the crystals, moving in the canal, that's what causes BPPV. The benign, paroxysmal, positional vertigo. Benign, it's not serious. Paroxysmal, when it starts coming on, it goes from nothing to very strong. Positional, it comes on in a position, and it's vertigo. It's a spinning sensation. So then I thought, winding up, and look at my clock here. What have I got? Not too bad on timing. I put some random thoughts down. Emotions affect things. Fatigue affects things. Joint problems affect things. Medication affects things. Blood pressure affects things. Hormonal fluctuations affect things. What you think affects things. Basically, everything. Most things affect vestibular problems in a negative way. That I can't think of one thing that, if you've got, quite marked vestibular symptoms, there's nothing that affects it in a good way. if you're worried and upset, if someone shouts at you in the street because you're drunk, the emotions from that, your vestibular symptoms will get worse. When you're really tired, but also vestibular symptoms are tiring, they make you tired, that will make you worse. Joint problems, if you've got a painful neck, we've seen that the vicious circle is, if you've got a painful neck to start with, vestibular problems will make your neck pain worse anyway. The medications you're on, if you look at any medication, look in the side effects, dizziness will be there. Blood pressure problems, in fact, usually from a vestibular point of view, low blood pressure adds to your symptoms because it makes you lightheaded when you change position. High blood pressure itself doesn't normally change vestibular problems unless it's massively high. But the thing is, that's worrying. You know, high blood pressure can be dangerous. Hormonal fluctuations, the women may know that the younger women, hormonal fluctuations, each month the fluid pressure with hormonal fluctuations, the fluid changes in your body. If that changes the pressure in the fluid in your inner ear, it can influence your vestibular migraines, it can influence any Meniere's type attacks. And your thought processes, you become forgetful. And then on top of that, I suddenly put, coronavirus on top of that. So what's that done? Well, these are only my thoughts and experience on the coronavirus situation. I'm not an expert in it. For the last 4 months, I've been at work every single day, locked in my office. So I haven't seen much of it, and I don't want to see much of it, but I've been in the NHS every single day. I've had quite a few patients who've had it on the telephone and speaking to them. And I'll say this, it is a nasty virus. And this is where you see all the people on the beach, they do not realise it is a nasty virus. I mean, yes, people have died from it, and that's, I suppose, the end point nasty, but even though it's only one virus, it causes different kinds of diseases in people. And that's what I think lots of people don't understand that. They think it's a respiratory problem. It's more than a respiratory problem. In fact, because I also work in hematology, it's a blood problem. It does things to your clotting. And that's why people actually get breathing problems, because they get lots of clots in their lungs, which is why they then need to go on a ventilator. And then they're paralyzed on a ventilator and they get blood clots in their legs. So a lot of people are having lots of problems from clotting because they're on ventilators. If you get corona symptoms and you're not in the, and we're not talking getting hospitalized in the worst situations, but just, a bad dose of coronavirus and you're still at home, your vertigo symptoms are worse. Everyone I've spoken to who's had coronavirus, their dizziness and vertigo got markedly worse. And again, I'm not saying because it's good or bad, I'm just telling you so you've heard it. And afterwards, the recovery can be really slow. Your recovery back to your base point. So this is people haven't got vestibular problems, take a long time to get back to normal. Some, and I would say even Boris Johnson, he doesn't look normal yet. I mean, not that he's never looked normal, but oh dear, this is going live, isn't it, somewhere? Oh, well, too late. You can probably delete that out. But anyway, he still looks ill at times. So, changes to work practice since lockdown. My appointments have been 99% phone calls. So car parking's been massively easy. Have to wear masks the whole time in the hospital, except in my office, Social distancing, well, we're getting used to that now. Some people actually, with vestibular problems, when I speak to them on the phone, have actually coped better in isolation because that's what they're doing anyway. They're isolated themselves. So for them, they're justified and they feel more comfortable, but other people are worse. The isolation makes them feel worse. I think there's been a lot of community support, but there's been a lot of more, possibly amongst patient groups, decreased activity. So less fit, less stamina, and people put weight on. So, and these are just, as I said, my things that hasn't been proven, but it's just what I feel. And as lockdown lifts, at the moment, my appointments are still mainly phone calls because you can do quite a lot on the phone. So a lot of people are still only wanting phone calls, so I'm happy to do that. So the face-to-face visits are starting. But the catch with that is now at the hospital, I usually have like a 15-minute appointment spot. When I do my face-to-face patients, they're taking so much longer because I have to change, I have to put hospital scrubs on. If I'm thinking of doing an epi or doing a hall pipe maneuver, I have to wear a mask anyway. I have to put gloves on. I have to put a plastic apron on. I have to have a face shield on, and then after the patient's gone, all of those have to be cleaned. So my visits are taking longer. And since I'm now booking out into October, November time in my 15-minute appointments, I'm running late more when I have face-to-face patients. So if I've got any face-to-face patients out there, just have to bear with it, because I run late because the face-to-face people make me run later, and that's without the car parking being a hassle. But there's a lot of fear and anxiety amongst people, a lot of lost confidence. So I think I'm winding up now. So, no, this is the coronavirus after effects. I got this from a website. I'll show you in a minute. These are the symptoms from the coronavirus after effects. So these aren't me taking them from a vestibular slide. I got these from some presentation at Harvard University about the coronavirus after effects. Fatigue. Well, we know that's good for not good for vestibular problems. Brain fog. Interesting term from Harvard. Brain fog is what lots of vestibular patients say they've got anyway, and the after effects of coronavirus brain fog. Vertigo. So people who haven't had vestibular problems have vertigo, and that's because they're getting little bleeds in the brain. So people have had strokes and they've had bleeds to blood vessels that supply the inner ear. These are all things you don't hear about in the world, but you read about them. Shortness of breath because their breathing problems remain, because their lungs are badly damaged. Hypertension, raised blood pressure because they've got lots of clots, and they have heart problems. So these are all the known problems after the coronavirus is gone from a person. So it's, I'd say it's worrying. So with those, if you want to look at them, there's a really good site. It's a government website. And then, because this is being recorded, isn't it, Kevin? This nod. Yeah, so that website, you haven't got to write it down now, but I put this screen picture from it. So yourcovidrecovery.nhs.uk, a very good website. And you go there, and then you go to the next page, and it said still feeling the effects. And each of these, look, breathlessness, about your taste and smell, them sort of managing fear and anxiety, fatigue, cough, all of those things. These are all things, coronavirus recovery. And when you click on these, this is just a picture, so I can't click on it. But when you click on it, what you get is you get a whole page articles come up, and you can print them up as PDFs. So I did memory and concentration, because that's one that a lot of vestibular patients have got problems with anyway, because they brain can't cope with a vestibular problem, so they can't think straight or concentrate on things. Well, people are having it with after the coronavirus as well. And so, there's just on that one link there's 4 or 5 pages of information people can take away. So when in ending, what I thought I would do, I've just picked out one thing, which I picked up from here, because the very similar advice is applicable to people with vestibular problems about memory and stuff. It's the 3 Ps. You've got to pace things, plan, and prioritize. You can't do everything, so that applies to people with vestibular problems, and it's from the actual website for people with post-COVID recovery. But just to bring it back to vestibular problems, and again, I think a lot of you have links with the VEDA Association, Vestibular Equilibrium Disorders Association. This is their website, www.vestibular.org. I find these 2 articles, 56 and 57, really useful, and you can download them as you go onto the site. You don't have to be a member of VEDA. On the emotional aspects of vestibular problems, there's 4 or 5 pages, because you know there's emotional problems, but it tells you about them. And then cognitive aspects of vestibular disorders, how to cope and why you're getting those aspects. So I have those printed up at work, and I show people them, and I say what I say was go to article 56 or 57 at VEDA, and then in the end they come back and they go, couldn't find it, couldn't know what you meant, so I end up, I print them up and give it to them. I'm not supposed to do that though, because they're copyrighted from VEDA. So I think that's my last slide. So I think we go over to questions. So
stop sharing, Andrew. That was brilliant, really good. I'm just going to unmute everyone.
Oh, you got 1 minute, Rupal.
Yeah, I'm just going to.
I'm going to try and hang around for a bit longer, because I'm really interested in some of these answers.
Just before you begin, Andrew, that was again another spectacular presentation, thanks. And it doesn't matter how long I've been living with my own condition, I keep learning something every time I listen to you. So if everyone would just like a quick round of applause for Andrew for what a great job he's done. Thank you very much. Over to you, Rupal, for question time.
Yeah, thank you for that. I've learned a lot. and it's certainly a condition that I've got myself. So I've learned things I didn't know about, Andrew.
That's good.
But okay, I'm going to jump straight into questions because I think a lot of people have asked very similar questions.
Are these the ones on the chat? Or?
Yeah, Andrew, Claire, and various other people, Kelly, I think, all talking about
The weather.
The weather.
Absolutely, yeah, and yeah, I would say yes. But if people are, especially if there's an element of the endolymphatic hydrops, if there's a Meniere's element to the problem, because when the pressure changes, you know, especially if you go from high to low or low to high in a big change, that's got to affect the pressure within in your system. So people have always said they can feel arthritis and they can feel the pressure change in their joints. Well, for the inner ear, absolutely. And I've seen enough people now that yes. So I don't know what you can do about it because the pressure changes automatic, but maybe being on things like beta histine, it's meant to be helping by sort of helping the fluid, the blood flow in the inner ear. So the answer is yes, it's a factor. Yes, it affects people. Yes, they can be barometers. And it's just actually real, not imagined. So does that answer a few of their questions?
I think so, yes.
And the other thing that weather can do, because I wasn't allowed, and Kevin said he didn't do this, but I was going to put a background of me, because the other day when I practiced this with Kevin, there was on my screens, I could have had me on a beach with clouds and waves, a video, like I was sitting on a beach, clouds going past, waves going past. So, and I knew a lot of people wouldn't like that because things are moving in the background, but it wasn't there this morning. And Kevin said he didn't take it away.
Honestly,
I wasn't allowed any backgrounds. So you got my study here.
Good. Andrew Hugill's got another part to that question, or well, certain question. Andrew, do you want to ask it?
Yeah, I was
just allergies.
Allergies.
Absolutely. Again, absolutely. Anything that
Sorry. Can we just repeat the question first?
Oh, okay.
Just because there are people on the phone that also might not see what the question is. So
how do you send the message once you've written it?
Just hit return.
Just hit return or enter.
Yeah.
Or you can just ask it.
So Andrew Hugill, do you want to ask your question?
My question was, do allergies affect these vestibular issues the same way that, say, weather pressure or the other things you've described might do?
Yes. Again, with many in the Meniere's research, with Meniere's disease, it's Meniere's syndrome because it isn't one disease process. You know, the end result is endolymphatic hydrops. So something causes the fluid pressure to change in the inner ear with Meniere's. And within Meniere's disease, there's subgroups. There's a group of people where allergies is the big response. And so as a subgroup, some people respond really well to treatment for allergy with Meniere's disease. So for them, the allergies is what's changing their the vestibular function by affecting the fluid. Whereas if you're doing a study on allergies in Meniere's and your group isn't that small subgroup, it won't show any difference. But I think in America now they're finding that the different groups, so there are some people with Meniere's that respond fantastically well to allergy management and those sort of things, and other people no response at all to that management. So that's where Meniere's disease is such a misnomer, Meniere's syndrome, because there's like an allergy component, there could be an autoimmune component, there's a migraine opponent. So some people with Meniere's respond really well to migraine management things and not the allergy bit. So that's where the Meniere's bit is quite challenging. But the simple answer is yes, allergies do. And a lot of my patients that haven't got Meniere's have got vestibular problems with hay fever in the summer. They're worse. It's because they've got a condition which is clogging them up through their sinus, increasing the pressure on their vestibular system. So even though in the literature you probably wouldn't find that hay fever makes vestibular symptoms worse, anecdotally most of my patients find if they have bad hay fever, their vestibular symptoms are worse. And to me it makes sense and again, it's one of these things. I'd say treat the hay fever as well as treating the vestibular problem.
Great. Claire, do you want to ask your question about pain?
Yeah, thank you. I was just wondering whether if you have vestibulopathy, can you also get ear pain or earache with it?
Yes, yeah. So with ear pain itself, so the pain in the ear, it's either coming from the ear, so you might have an ear infection or swollen eardrum or something. Well, doctors are good at looking at that because they can look in and say, oh, it's all swollen, that's why it hurts. But quite often, as you'd probably know then, you go in and say, no, it looks perfectly fine. Perfect. But your ear can hurt because your jaw sends pain into the ear. The top part of your neck sends pain into your ear. So there's two musculoskeletal sites refer pain into the ear. So and if you're tense and anxious because you've got a vestibular problem, your jaw joint, you've got your muscles here tensing up, can upset your jaw and it sends pain in the ear. Your neck muscles the same way. But also, if things aren't right in your ear, there's lots of little muscles with the ear bones, and you can get tension in around that system. And then I'm not an audiologist when I say that, so don't, Michaela, laugh. Little ear bones, and Andrew Hugel and say little ear bones and tension and stuff. But so tension in the system can create problems of pain. So the answer is yes. And it may be something as simple as an ear problem, but more than likely it's neck or jaw or from the ear itself behind the eardrum.
Okay, thank you.
Right. Question from Sue. Sue.
Oops. Hi, Andrew.
Hello.
I'd just like to know how long after having repositioning manoeuvres can you restart your vestibular training exercises again?
Oh, okay. Well, normally we'd say after you've had, say, the epi manoeuvre, we would give advice for the first week or so. You've got to be very careful how you sleep and up. So we tell, I know Peter does as well, I'd say two weeks before you start again.
Okay.
But we are fairly, that's if you've had one epi manoeuvre and it's your first one, and then we give you a break from the exercises, because the rehab exercises aren't going to work immediately after an epi manoeuvre, because, you know, really you've had things moved around, you've had this little crystals tipped all the way through your ear, so you can feel really rough for 2 weeks after an epi. So we say, well, don't start then. I have some people who have so many epis and they've been doing rehab a long time. They can keep doing their exercises. I mean, there's no scientific reason you can't keep doing your exercises. We would just say that if you're feeling rough, we give you a couple of weeks leeway for feeling, adding my exercises to the feeling rough. So in a way, it doesn't matter. But as a general rule, if it was a first time epi, we'd say nothing for 2 weeks.
Okay, thank you.
Brilliant. A question from Sandra as well. Sandra, do you want to ask Andrew your question?
Yes, please. Andrew, I've heard and read a little bit about the neuroplasticity of the brain.
Yep.
When you talk about the brain being oversensitive, which is just, you mentioned that with the triple PD.
Yep.
Do the exercises, the vestibular exercises, help that? Is neuroplasticity involved in the compensation? Is that what's happening when?
Absolutely. That's what vestibular exercises are. That's why they work, because of neuroplasticity. So neuroplasticity is the ability of the brain to change something.
Right.
So with vestibular exercises, what they're doing is they're using that principle, and the brain is retuning. Say, if we said one ear is out of balance with the other, and this is saying this and this is saying this, with neuroplasticity, over a 3 to 6 month period, the brain sees it level. So we haven't fixed the damage, so it's still only firing at, say, half the firing rate that it used to, but the brain has retuned it so it sees that as the same as the other side. So, and so for that to fix takes a long time. It starts as soon as you start the exercises, but it takes to become fixed like that, so the brain sees it, takes 6, 8, 12 months to stay fixed. But even then, if you have a life-changing event, that can upset everything, and the brain suddenly sees it like this because the damage is still there. Right. But it will retune again. So that's a neuroplasticity bit. PPPD bit is the brain is just generally hypersensitive to everything. Smells. It's almost like migraine. It smells, touch. Everything can be sensitized, and movement is one of those things. So the exercises are in. So if a person, we wouldn't give exercises purely for migraine, for example, purely for migraine. So because the the exercises don't desensitize things. If anything, they provoke it. So the exercises have to be used carefully with PPPD, and that's why I take those people slower, and it's got to be a gradual build up. So we're trying to correct the vestibular problem, and that's why some people have to have the medication as well. At the moment, and you can't quote me on this, but there's so many people here, someone probably will, I think PPPD has been overdiagnosed and overused. I've had, well, I can't give any details. I've had a patient in the last 2 weeks, I can't see their name on here, sent to me not by one of our doctors, by a doctor that isn't an ENT doctor, isn't a GP, with a diagnosis of PPPD. And it's not PPPD, and it's quite difficult because the person's problem is harder than that. And I can't say any harder than that, but I've now been left with a patient that hasn't got PPPD and thinks they have, because this other doctor has downloaded all the paraphernalia and said, this is what you've got, you need rehab. And I might be able to help them, but it won't be rehab. It'll be counselling, it'll be PTSD and all sorts of things, but it will not be vestibular.
Is it difficult to diagnose between triple PD and?
Well, yes, PPPD is diagnosed by this person's description of symptoms. So it's when they're very motion sensitive all of the time. And so vestibular patients can be that, but until you've tried normal exercises, I mean, I would say until you've done a normal rehab program, you can't say you've got PPPD, because you might get better. You might be sensitized to motion, and you just do the vestibular program and don't need tablets, and you get better. So it's just a label on top when people have had vestibular symptoms for a long while and they're very motion sensitive. So, and then there might be characteristics that push them that way. If they are a migraine sufferer, that pushes them that way. If they're a very anxious person, it pushes them that way to make them sensitive to motion.
I see.
All right, Sandra. I just want to see if anybody on the phone has got a question, or anyone else that hasn't been able to write a question on the screen. I can hear somebody on the phone. Who is that? Is that a question from anyone on the phones?
And if your name's Penny, you're muted. So we can't hear you anyway, Penny.
There's someone else that is unmuted.
Yeah.
But I'm not sure who they are, but I don't know if you've got a question. Have you got a question for Andrew? If not,
anyone else in the meeting?
Ella, yeah, I think Ella's got a question. Ella, do you want to ask your question if you just unmute yourself? Kevin, can you unmute Ella?
Yeah, I'm trying. Yeah. It's not
okay, here we go. Ella, I think
you're in the room.
Is it unmuted?
Yeah.
So we can hear you.
Yep.
Go ahead.
Yes. Well, my condition has affected my walking, my physical mobility, and I just wanted to know how why that is. Why is it that I get very fatigued when I walk a short distance? And I mean, I think the vestibular rehab exercises have helped my balance, but I'm still struggling now with my physical body and my legs and walking.
Okay, well, there might be other additional problems. There might be joint problems, you might have arthritic knees, hips, that sort of thing. But otherwise, with vestibular problems, everything has to work so much harder. So everything gets tired doing nothing. Walking should be automatic.
Yes.
But if there's a problem anywhere with the system, ranging from ears through to your joints, to your muscles, it has to work harder so that your legs will get tired. So any other problem might be amplified. But otherwise, if your vestibular system is getting better and your balance is better, it is a matter of fact of gradually pacing and building up your walking, and not walking too much into, see, if you were training for a marathon, you have to push into stamina to do stamina training. But if your problem is a vestibular problem, and when I tell people they've got to do walking as an exercise, it's from a vestibular point of view, it's better to do 3 short walks rather than 1 long walk. Whereas if you were doing walking as an exercise to get your heart better or your muscles or your knee better, you'd want to do 1 long walk. But from a vestibular point of view, it would be better to do a short walk and then recover. And then maybe in the afternoon, another short walk and recover. And that isn't as good for your heart or your legs or other things, but it's better for your vestibular system to retune. So it's that fine line, changing from that vestibular process into doing it into fitness process. And that's what you've got to find, that fine line, trying to push the boundaries, but not going so far that you become absolutely shattered, because then everything will be worse.
Yes,
that helps.
Yes, my husband describes me as being, my battery has suddenly gone. You know,
if that happens with walking, at that you have to respect that. And so you have to maybe do a walk somewhere where you can sit and recharge your battery.
Yes, certainly that happens, doesn't it? I'm trying to think, is there anything else? No, thank you, Andrew, that's really, really helpful.
No, can't see any questions.
Ruth, you're muted.
Anyone else that I can see?
Nicola's waving at me.
Nicola, go for it.
I've had the triple PD for 3 years now, and I was treated by you, Andrew, and I use the exercises still. And it's the same pattern. It sometimes it's worse than others. The swaying, the looking at the computer screen, the motion movements, and I do all the exercises. Am I ever gonna get any better, or am I just, this is life and I just continue with my exercises and manage it as I do?
Well, it's very difficult to ask. I mean, have you tried the medication though? Have you tried that at all? For the people, I say you needn't answer it because you want to.
No, that's fine.
I say, have you tried the medication? Because I have got some patients I've seen at the Balance Clinic at the Royal who've had symptoms for such a long time, and they've got to the point where I say, well, this is it. This is how it's going to be. It's not going to change. But then the new label of PPPD came out, so I'd written to their GP or I'd spoken to Professor Ray, and they tried the medication, and I can think of 2 people who I would have put into my category of, well, I can't see them ever changing, that's it, that's as good as it's going to be. And one of them was only in their, I think, 40s or 50s, and one of them was in their 80s. Since they've been on the medication, they've changed massively. Just so the medication can make a big difference, and they're not on a depressive medication. They're not on. They're just on the dose to take the edge off the sensitivity, and then so I've seen some really big improvements on the medication.
How long would you be on the medication for?
Well,
a lifetime?
No, not a lifetime. But one, if it's helping, sometimes you think, well, why come off it? But it's only very low when they start, and it has to be upped by whatever the doctors say. But normally, the medication can feel strange for the first 2 or 3 weeks, as any sort of antidepressant can. But then normally within a month or 5 weeks, you'll know if it's helping. And then I think Peter tells people they have to be on it for a minimum 6 months. But all I can say is with PPPD, the people I've seen who weren't changing with exercises, when they were put on the medication, there's been some massive changes. They still need the exercises as well, but there's some massive changes.
Does that help, Nicola?
Yeah, very much so.
Okay.
Yeah.
A few last questions from me then, Andrew, before you disappear. Yep. You talked about GPs and identifying the correct conditions. How much training is actually offered to them, or I don't know if training is the right word, but information in terms of helping them to understand balance conditions? Because I think
whenever we write to them, we try and write, especially when Peter writes very detailed letters to them. I mean, I write, when people are better, I write a letter telling them how the patients got better. So that's from the hospital when they've sent people in. We've had several GPs that have had this problem, and they send very good referrals, as in very appropriate, understanding referrals. And they also give people the correct advice early on, which is important. But there was GP training programs, but all that's gone to pot with Corona. And then getting to GPs is sometimes quite hard, which is something the Meniere Society has found quite challenging to get, you know, information into the GP practices. But it's just something we've got to keep trying to do.
Okay. Waiting times. What are current waiting times? Do we have any idea for referrals to the clinic?
Oh, I've got no idea on that. Because if you look at the last, even though I've been really busy and my list has been full on phone calls, a few of those have been new patients that have had assessments. But as of last week, the balance testing hadn't started yet. So there's a huge backlog of people having balance testing. And so quite often when I see the consultants, they say, oh, have balance testing first before seeing Andrew. So it's, I don't know is the best answer.
All right. One final question. And this I think is really important for a lot, but you talked a lot about, you know, the psychological effect and how much support is there? Why isn't there more psychological support for people with balance conditions then?
Well, I think because there isn't enough psychological support for people with mental health illnesses. So there's a lot of people with, if I say full-blown mental health problems that aren't getting psychological support, whereas at least with vestibular problems, as I was saying, they develop psychological problems as part of the vestibular thing, but that I wouldn't call them mental health patients. So hopefully if they're seeing people like Michaela, who's on screen there, me and other people at the Balance Clinic, we try and do a counselling element. We have some links with psychology, but there just aren't enough psychologists out there. So that's where something needs to be pushed for more psychology, because the thing is the psychologists in the NHS are either like with pain clinic, because it's seen as a branch of pain clinic, and possibly with cancer stuff, or.
But is there not something that can be attached to the balance clinic? I know Michaela was kind of looking at. I can't remember. It's called now, Michaela. It's gone out of my head completely in terms of helping
mindfulness
people.
and hypnotherapy and that sort of stuff.
Hypnotherapy, that's the word.
But when Michaela's doing that, and that is, but there isn't psychologists in the hospital that we could refer to. So for that, if we did, it would probably be like a 2-year wait, and so there isn't actual psychologists that we could actually invite to come part of the clinic. We did at one point a few years ago invite a dietitian to be part of the clinic, and she was good, and she would see some of our, especially Meniere's patients. But touch wood, and because I'm involved with Meniere Society a lot, and having worked with her, I'm able to give the dietary advice, and we can refer through to dietitians. So there is a mechanism there for people that want dietary advice, either for migraine or Meniere's. But also those websites, the Migraine Association, the dietary advice for normal classic migraine applies just as much for vestibular migraine. So it's the same it's the same dietary triggers are the first ones we look at addressing, and some of those overlap with things for Meniere's as well. Caffeine being the biggest culprit. So,
all right. Anybody, any final questions? This is your last opportunity for today. If you want to ask Andrew anything else,
on their photos or their videos.
Nope.
I can't wave at them because.
No, I think. Well, look, I think we'll leave it there. Andrew, thank you so much. I'm going to hand back to Kevin, who.
So I might disappear now because my dog was barking earlier. I better go and see what's happening.
Andrew, thanks very much again.
Okay, so I'm happy to do this sort of thing again. I mean, and to expand on, because how many people can put their hands up? How many saw my other presentation I did live at the race course? How many of them saw that? Probably only half there, because I say that because I deliberately didn't go down that line of doing those sorts of things. That, where I talked about vestibular rehab in more detail. So there's all things.
Andrew, I have to mention for anyone watching this in the future, if they visit our website, lifeonlevel.org, you can view the video of your presentation.
No, there wasn't anything.
It's also on our Facebook.
Yeah, Facebook and YouTube channels. But Andrew, you deserved your lunch. Yeah, you have that lunch. Thanks ever so much for your time and sharing.
It's easier than I thought it was going to be. But then I hopefully didn't speak too fast. It's very hard when you just talk to a computer.
No, very good. You just click leave meeting.
Okay, I'll click leave and run away. Okay, thanks then.
Thanks, Andrew.
Bye.